presentation is titled Enhancing Encryption Measures for Expanded HIPAA-Covered Entities, presented by Veronica Chernick and Rebecca Stowe. Please come to the stage. Thank you.
Hello, judges, and thank you everyone for being here today. Now, as technology advances, there's an urgent need to update the protections of our health information. In the healthcare industry, HIPAA plays a pivotal role in enhancing patient data privacy. However, we have identified two very alarming loopholes that leave our data vulnerable to breaches, hacking, and fraud. My name is Veronica Chernick, and this is Rebecca Stowe. Our solution today is an excellent step forward in improving healthcare security in a digitalized world. Our presentation today will follow the outline of our white paper, introducing the problem, explaining our proposed implementations, and discussing our legislative plan, with some time for questions as follows. This first section will introduce the problems we identified.
Let's welcome our patient, Didi. Didi had been feeling unwell these last couple of days and decided to visit her local hospital to get checked out. Upon entering the hospital, she was greeted by friendly staff who then handed her a HIPAA compliance form. Didi signed this form without any hesitation, ensuring that her sensitive health data would be protected securely.
This form that the patient signed is known as HIPAA, the Health Insurance Portability and Accountability Act, enacted in 1996. Although it is commonly used for consumer privacy, its fundamental focus is on secure data portability. We kept this fact in mind when developing our solution. Unfortunately, there are two major shortcomings. One is that HIPAA-covered entities are HIPAA is only applied to limited covered entities, and second, once data has been de-identified, it is no longer covered under HIPAA. Current covered entities consist of health providers, such as your doctor, dentist, and psychologist, health plans, such as your insurance companies, and clearinghouses that convert and manage your health data. However, this does not include any websites, apps, or other web organizations, like Fitbit, BetterHelp, and reproductive health trackers. This is a big problem, as more and more individuals resort to these online health tools for faster or cheaper access to health information and treatments. They offer no standard of protection that traditional entities provide. By not including these organizations under our covered entities, we take away the privacy and security rights of individuals who have limited access to conventional healthcare.
The second loophole to obligatory HIPAA compliance is related to de-identification. De-identified data is data that has been stripped of any personally identifiable information. Under HIPAA, there are two ways to de-identify data. The first is the safe harbor method, and this includes the removal of 18 types of identifiers. The second is the expert determination method, and this involves the application of statistical principles by a so-called expert, who then renders the risk of re-identification as extremely small. No matter the method applied, de-identification is not a perfect protection of privacy. First, there always exists some risk of re-identification. This risk has been accelerated by recent advances in artificial intelligence and machine learning, which can quickly aggregate residual information and match patients' identities in de-identified data sets. Further, once data is de-identified, it is freely bought and sold without any regulation. In fact, the sale of your de-identified health records has become a multi-billion-dollar industry. Factors such as the ease of re-identification and the mass sale of electronic records can contribute to the breach of patient trust and confidentiality in our healthcare systems.
In fact, a study by the Journal of American Medical Association conducted a study to measure the feasibility of re-identifying de-identified data. The study concluded that just under 95% of all adults in the study were easily and accurately re-identified using machine learning technology.
This next section will discuss our proposed implementation, which targets the two loopholes in health data privacy. Our solution involves the application of a data ledger. A data ledger is a secure and tamper-proof record purposed to increase consumer transparency and enhance overall data security. The details of our data ledger are heavily inspired by Google's DeepMind, who embarked on a verifiable data audit project. This project included the creation of a data ledger with 3 key features. First, the ledger recorded patient metadata, which are tags about each data interaction, including type, location, and reason. Next, the ledger was append-only, meaning that once data was added, it cannot be removed. Finally, the ledger has misuse detection features implemented. These features raise alarm bells if data is attempted to be altered or accessed by an unauthorized entity. In addition to the 3 features proposed by the Verifiable Data Audit Project, our ledger has an increased reliance on Merkle trees. Merkle trees are a data structure built specifically for the synchronization and verification of big data. They take in a data point, such as your PHI, and encrypt it using an algorithm. Additionally, as new data points are added, all previous points are re-encrypted in a process called dynamic data obscurity. The topic of de-identification can be quite technical, so I would like to direct your attention to a play which will parallel our proposed practices. In this play, there are 3 key features. First is the driver, which represents your PHI. Next is the license plate of the vehicle, which represents the identification code of your PHI. Lastly is the officer, who represents a corporate or data broker figure. In this example, the driver passes by 3 lights, each equipped with automatic license plate reading technology. As a result, as soon as the driver passes the first light, her plate is scanned and her identity is known. This is the case analogous to PHI traveling with no protections. In the second case, the driver is equipped with a dummy license plate. As a result, as she passes by each of the lights, her plate is scanned, but her identity is not known. However, if you aggregate the location of the vehicle across the 3 lights, you can trace her to her residence, where her identity is finally uncovered. This is a case analogous to the privacy protections of current de-identification standards. In this final case, the driver is now equipped with 3 dummy plates, which she changes before reaching each light. As a result, it appears as 3 completely different vehicles are registered. The driver's identity is never known, nor can she be traced to her residence. This case is analogous to the privacy power of dynamic data obscurity.
We can use this new method for data storage security and expand it to all organizations that collect comprehensive health data, including websites and health applications. Expanding this data can lead to some benefits. For example, unified data can allow us to have a standardized model for data storage. We can also improve portability, as it's easier and more seamless to transfer information between providers. Next, with increased sources of inputs, such as more organizations feeding in the information, the individual's data ledger will be re-encrypted every time a new source is appending to it, and this will allow for more data safety. Next, firms can benefit from this, as it will allow them to concentrate on their specialization, since the burden is lifted off of those individual providers and onto the centralized entity. This can also benefit small businesses, as they can focus their efforts on, or they can rely on network effects, so it's more affordable for them to provide this source as opposed to, before the data ledger, they wouldn't be able to, as it would be more expensive. Lastly, we have improved transparency with consumers and organizations. We aim to implement the access, correction, and deletion features in our data ledger. For access, consumers have the right to view and see who has that information stored on them. Next, they can append or correct any data in their ledger. Lastly, while deletion in the traditional sense is not really working with the data ledger, we aim to give consumers the ability to permanently block or restrict data sharing with organizations they no longer wish to use. They can also revoke consent to share any future information. Additionally, consumer data will be automatically opted in for medical research, but opted out for targeted advertising. These, however, are just defaulted functions, so if consumers choose to change it, they can do so easily. The costs to implement this ledger are going to be funded by a subscription model. Now, the estimated annual cost for this is no more than what organizations currently pay for data storage and HIPAA compliancy. Consumers will be able to freely use and share this ledger. Hospitals and researchers will have a flat fee based on verified health personnel, and other organizations will be able to freely append to this ledger, but if they wish to use that information, there will be a small fee applied per data access. This next section will target our legislative plan. Almost all health organizations are converted to electronic records to store their data. And more recently, organizations have adopted or plan to adopt cloud technology in their data storage use. But while cloud offers some centralization benefit, there are still some portability restrictions due to the design of the organizational data silos.
Our solution seeks to target these organizational silos and critically focuses on PHI rather than the more general electronic health record managed by current cloud technology. When discussing implementation, this 5-step plan will be referenced. The first step involves defining the use case. Our ledger is crafted to handle PHI and PHI that is aggregated from many sources, from hospitals, from the broader covered entities, and from third-party application. Further, comprehensive anonymity will be established by implementing technology features which protect against re-identification and increase data transparency for the consumer. When considering technology selection, our ledger is heavily inspired by Google's Verifiable Data Audit project. Additionally, an increased reliance on Merkle trees will allow for the effective synchronization and verification of big data. PHI will thus be protected in its life cycle of collection, storage, and retrieval. When considering technology selection, a distinct choice was made to use the framework provided by the audit project as compared to other ledger solutions such as blockchain. This decision was made in consideration of one main factor: centralization. In blockchain, once a ledger is produced, it is verified independently by a group called miners. However, since our ledger deals with sensitive health data, we believe that centralized verification by a governing authority will help establish public trust in our system. The third step in our plan involves network architecture. Resilience is a key component of this. Resilience deals with the ability of a network to continue functioning in the face of adverse effects. By standardizing resilience, we seek to minimize downtime and data loss in case of a network disruption. Further, consensus models will be established, which will allow entities to communicate seamlessly through the network. The fourth step in our implementation plan involves developing a governance model. We suggest that ledger verification be issued by the Office of Civil Rights, the agency that is currently responsible for enforcing HIPAA compliance. Within the office, a subcommittee will be established who will act as auditors. These auditors will embark on annual reviews to ensure data is properly written in real time and following obligatory cryptography standards. Finally, a steering committee will be established where interested parties can send a member to advocate for desired ledger rules. Our proposed ledger is fully compliant with HIPAA. In fact, the identification standards are not only met, but they are raised. Additional security processes are in place which will detect HIPAA violation. If a violation is detected, penalties will be unrolled.
In terms of cost for this implementation, we are expecting to see slightly higher upfront costs as we aim to implement a unified data ledger. However, we expect significant cuts in administrative, maintenance, and enforcement costs by design of ledger. Our goals for this project are as follows. By 2030, all Tier 1 hospitals and major web organizations will be integrated into this data ledger. In the following 5 years, the remaining covered entities will be joining them. Now, it's important to note that currently we have a very, very fragmented data system, and this makes, with each organization having their own privacy protections and storage limitations. So this will make it difficult to unify initially, but this is precisely why we have to take this action now.
Once our ledger is implemented, success must be evaluated. Interoperability is a key component of success, and it involves the ease of implementation within current system. Since the majority of hospitals are collecting and storing data online, we believe that our proposed ledger would be highly interoperable. Additionally, a sentiment analysis will be conducted. This analysis will seek to isolate attitudes, opinions, and emotions expressed by healthcare providers, patients, and organizations towards the ledger. Both interoperability and consumer sentiment will be analyzed at the annual level with the goal of seeking points of ledger improvement and classifying the public response.
Now let's see how our patient is doing after their hospital visit. Dee Dee safely shared her sleeping habits from her fitness tracker to her doctor for more tailored healthcare better suited to her conditions and needs. She left the hospital feeling safe and secure, knowing that her data is better protected than ever before. Thank you so much, everyone, for listening, and we're looking forward to your questions.
Thank you very much. That was great. Questions from the judges? Lisa?
I'm going to ask two since somebody asked mine last. Who, and I think this is one that the other judges might also have, so who builds and manages this ledger?
Initially, we were saying that verification would be done by the Office of Civil Rights, which is under the Department of Health and Human Services.
But who actually architects the ledger and builds and maintains it?
I believe that if we're seeking to establish public trust, we would need it to be built by government party or a government contracted party. This is similar to the case of blockchain. It is a similar technology, but because it is contracted by individuals, many individuals do not trust the system. Having that government body name stamp the construction of the ledger could allow consumers to be more trustworthy in entering their data and using the ledger.
I would challenge that given the technical debt that most government departments and offices have and the data breaches like OMB and VA and other issues that they've had, they might not be the best party. So what happens, so this solution also relies heavily on encryption. What happens in 3 to 5 years when we or the Chinese get to quantum and that breaks encryption, or AI beats quantum to it and that breaks encryption?
So this current dynamic data obscurity actually works very well with this system. So the more sources we have, the faster this data is re-encrypted. And so while it is possible to develop certain technology to break it, it will be very challenging to get to that point that quickly.
I'm going to add an additional point to that. De-identification is an imperfect measure. And like you said, there's new advances in AI and machine learning, so we will always be at a race against keeping up with these standards. But at the bare minimum, this ledger gives consumers the ability to track the location of their data. So that is a feature we could keep to give consumers at least some bit of transparency, considering that, again, we will always be at a race against machine learning and artificial intelligence systems.
So you talked a little bit about a process for access, correction, and deletion of records, and so I'm hoping you can elaborate and expand on that a bit. Specifically, is this something that consumers, patients can unilaterally go in, make changes to their records? Do they need to, submit an official complaint to OCR? What does that look like?
Yes, so if it's basic demographic information, the consumer will be able to directly change that data. However, if it has something to do with like a provider recording the information, they can discuss that with the provider, and then the provider will append that for them.
So in the event that an individual disagrees with their provider over something or doesn't want their provider to include a record, is there a mechanism for them to request deletion, sort of overriding that?
Yes. So deletion is a right that the consumer has, like, of themselves. They don't have to ask anyone to restrict data. So certain data they won't necessarily have access to, but overall, if they no longer want to use a provider or an app, they can, block that access and not worry about them having information on them anymore and go to a different provider.
Would you, you talk about putting this in one big database in the cloud. Have you thought about how many different providers and how many different clouds you would use to protect infiltration and of just one master cloud?
I think we'd have to do one master cloud, but we realize this project is quite a big embark. So if we were to go about implementing this in reality, we wouldn't start with implementing every detail of the PHI. We'd start with just a simplistic version that looks at the metadata, these tags about the data interaction and so forth. If that is successful within this one cloud system, if it could handle that amount of data, we'd progress to the next phase, which would include providing more details about the data into this ledger system.
Do you think the fact you would have one cloud and one provider would create major obstacles to getting implementation of such a program?
It would definitely be a challenge, yes. To say the least, yes.
The answer, I think, is yes.
Yeah.
So I was wondering, with any policy change as large as this would be, one of the issues is accessibility. And I was wondering if you considered whether there would be people or groups of people who may be left behind if you implemented this type of ledger. People who may not have access to the internet or reliable access to the internet, or other people who may just not be able to access their data in this way in a reliable means. So I'd like to hear your thoughts on that.
Yes, so we actually discussed about implementing a potential sort of app to store this data ledger, and some of that information will be directly stored on the device. So like the most recent information can be accessible without online connection. In terms of people who may not have an electronic device to look at it in the first place, we want hospitals and other entities like that to be a safe place for consumers to go in and see record of their data.
I think you covered that well.
Well, I think to answer the other question following up on mine, the government has demonstrated that they can have one major database, Medicare, that consists of executive places, but there's a national database, so the obstacles aren't as great as I might thought they would be.
Thank you for providing your insight to us. Much more experience than all of us.
And by the way, this is the Holy Grail. What you're talking about here is the Holy Grail of data information and storing, so we can have sharing of information, and because it's a very cumbersome system and the hospitals don't want to share. And if you were able to pull this off, you would be doing a great service. Thank you.
Veronica, Rebecca, thank you so much. That was great.